Okay. All right, everybody, we're gonna so hopefully you can grab an article, grab some set of articles if you haven't done one already, and then Mona will sort of go through it with you guys as you guys peruse the manuscript.
Okay, we're gonna start off with a case. Does anyone want to read it?
Sure. A 68-year-old male with CKD stage 3, insulin-dependent diabetes, presents to the hospital with fever, right upper quadrant abdominal pain, and transaminitis. Vital signs are T of 39.1, heart rate of 120, respiratory rate of 22, blood pressure 90/60. Exam is notable for lethargy and right upper quadrant tenderness. Laboratory analysis reveals a white blood cell count of 16.1, a creatinine of 3.1 from a baseline of 2, and a lactate of 3.6. CT scan reveals a 10-centimeter hypodense liver leak. Which fluid would you choose for his initial resuscitation?
So who says normal saline? Who says plasmolite?
What's his K?
Who says lactated ringers?
No
Albumin? No fluids? Okay. So today we're going to be talking about two articles that came out in New England in February on balanced crystalloids. Some of the background on this, as I'm sure we know, normal saline is equal parts sodium and chloride, but actually 154 milliequivalents. Of course, we know it's an isotonic fluid. And the main problem with normal saline is that it results in hyperchloremic metabolic acidosis. And it's been associated with questionable effects on the immune system and also with renal dysfunction. Lactated ringers, there are a couple of problems with this. It's relatively hypotonic, and then excess administration can result in hyperlactatemia, metabolic alkalosis, and hypotonicity. The other problem with lactated ringers is because it has calcium in it, sometimes, I guess in theory, if you infuse it with a blood product, because of the citrate, it can result in chelation and microthrombi. And then the problem with plasmolite is that it contains potassium. That's the main problem, and it's expensive. So this is a breakdown of the composition of the different crystalloids. So you can see the saline has 154 milliequivalents of sodium and chloride. The pH is very low, 5.7, and the osmolality is high at 308, compared to lactated ringers or plasmolite, which are more balanced solutions. Okay. So there's a lot of words on this slide, but basically before these two articles came out, there were two articles, non-more randomized controlled trials, but this is what people were using to justify use of plasmolite or lactated ringers. So this article was a retrospective cohort study, basically looking at surgeries. And they looked at primary outcomes were major complications, including respiratory failure, cardiac, GI bleed, sepsis, and acute renal failure. And then the secondary outcomes looked at electrolyte disturbances and rehospitalization. And you can see like the majority of people received normal saline versus plasmolite. But what they found was the use of dialysis was 5 times higher in the normal saline group. And there was a difference in unadjusted mortality rates. The other article that people cite a lot was this UNIS article, which was basically a before and after study. And it was looking at basically before there was a 6-month control period where physicians were allowed to use any type of fluid they wanted to. And then they did education on the composition of fluids and allowed physicians to then they studied what physicians used afterwards. After the education, there was more plasmolite used and more lactated ringers. And basically what they found was that normal saline resulted in higher creatinines. Use of the balanced crystalloids had decreased rates of AKI, and then also decreased RRT. So this is where they came up with that maybe there's some benefit of using the balanced crystalloids in terms of renal protection. So now so there were two articles that came out in the same issue. One was looking at non-critically ill adults and the other was looking at critically ill adults. So I'm going to talk about the non-critically ill adults and Teddy is going to talk about the other one. So this is saline against lactated ringers or plasmolate in the ED or SALT ED. Basically was a single center study. It was unblinded, multiple crossover trial. It was done over a year at Vanderbilt. And they included anyone who received 500 milliliters or more of fluid and then was subsequently admitted outside of the ICU. So they basically randomized these people to receive either saline or plasmolate or lactated ringers. They could choose which one. And they changed every month. Basically, the selection of the randomization actually only occurred in the ED. So once they got up to the floor, providers could use whatever fluid they wanted to. So it was only in the ED that it was restricted. They looked at hospital-free days and a composite of in-hospital death and length of stay for their primary outcomes. And for their secondary outcomes, they looked at major adverse kidney events, which was death, use of RRT, or increase in creatinine more than 200% of their baseline, and in-hospital. So pausing here, I'd like to have some discussion about what you guys think about the methods. Or there's yeah.
Well, I mean, as far as the results, it's just going to be hard to say. It's depending on what they got before. It's only use a small fraction. I mean, certainly at the beginning of their research, something important. It's still going on.
So there's potential for a lot of crossover. So you could be randomized crystalloid, but end up getting way more.
That's okay. So you can't really see this, but
So did the others talk about why they didn't do it? What was
they
it?
didn't.
Was it just a practical issue?
Yeah, they didn't specifically say. I think it was more a practical issue, but I think in your study,
I mean, the way they randomized was by cluster. So it was by like the unit that they presented to, either in the ED or the ICU. So there were different, I guess, emergency center like units or sections in their hospital. And they did that because it was practically much easier. I think they were also concerned that if they didn't do it that way, that there would be some kind of leaking of practice from one patient to another because the same provider could be taking care of like 8 patients kind of the same protocol. So I think once they left the ED, there wasn't like a practical way, so they're going to keep them in the cluster.
and we'll go through the results in a second, but they didn't. I mean, they didn't mention. I guess they weren't recording it in terms of what type of fluid they got once they left. So we actually have no idea. We only know the ED.
But do we know the median time patients stay in the ED?
No, they didn't. They didn't cite that right now, which is also interesting. Okay. So
Like, as opposed to we do it in places like ours versus some
Right.
places
Right.
in the middle.
Although it's Vanderbilt, so presumably it would be like equivalent to our like to stay in the ED.
Differ.
Anyway, they were pretty similar groups. The only difference was, and maybe I don't know what you guys think about this, but they did note a difference in terms of statistically significant difference in terms of the level of sodium and chloride. So the results, they had 13,000 patients. In the ED, they received a median of 1 liter. Most of it was lactated drinkers, and then 5% was plasmolate. 88% received the assigned crystalloid solution, and they did an intention to treat analysis. So this is what they found. Basically, there was no difference in lead-in hospital-free days, but there was a difference in major adverse kidney events. But if you look at kind of the breakdown of each, there's not a difference, but when you do the composite, there is. And then there was no difference in terms of stage 2 or higher AKI or in-hospital death. What do you guys think of the results?
The amount of food is pretty small.
Yeah.
Overall, like 1 liter, medium,
It was only 1 liter, and then we have no idea
Maybe
kind
they're
of what
paying
happened
for this.
afterwards. What do you guys think about 88% compliant in terms of the protocol? Do you think that's good or?
Why is that happening? I mean, I guess that's the question.
Why is
They
it-
actually cited it as a strength, having 88% stick to the protocol.
I guess.
We can talk a little bit more in,
It's opposed to back, so I think it should be higher. I know you gotta follow the protocol.
Also, the way the protocol worked is they were randomized by cluster by where they were, but the providers were allowed the choice, the option to use the opposite crystalloid if they thought it was more clinically indicated, or if there was a relative contraindication. So if there was hypertonia and you didn't want to give a balanced crystalloid, you were able to choose.
Or maybe the patients got better so fast they were discharged before they could even proceed.
They would be
There's
included
always
in
an
this, right? They'll be excluded. But like, actually 88, I thought is a pretty high number of compliance because even core measure, when we start out core measure, and core measure like aspirin or metoprolol, all those, we start very low, like in the 30 to 60, and then eventually good ones are like in the low 90s. So 88, I thought it was really fantastic. Yes.
anticoagulation.
Yeah, and I think it gets back to the question of like, do you believe that this intervention, like the first year, is meaningful or 30 days? So like, even if they were 100%, if you don't think that that's meaningful, then it sort of becomes less impressive. But I feel like for just any protocol, getting 80% people for patients to receive the thing that you want.
Yeah.
But
Although
it's
then they
so
found a significant difference. So,
Which is
But those outcomes,
Yeah.
secondary outcomes, composite outcomes are all in-hospital composite outcomes, right? Not
Yeah.
28-day outcomes.
It's
Oh, 30
days.
days.
Oh.
Could you talk about what the indications for the fluids were and in terms of the groups? Why were they getting fluids?
I think, I'm not sure.
There's more data on that in the intensive care unit. I don't
I'm
remember.
not sure if they cited that in the.
It might have been one of
Majority of the patients appear to be medicine patients.
Yeah. Well, if you think
They
about
were
it,
all
hardly
medicine.
anyone gets fluid.
Yeah, but why, right?
Yeah.
The other thing is they've got these composite outcomes and whether we think that the components of the composite outcome are meaningful. So depth or length of stay, I would argue one of those is much more clinically important than the other. Then they have this,
You mean the one you say?
yeah, one of those affects my bonus.
Right, exactly. That does affect the bonus. So
They
they
may not
have-
be independent variable.
Then this make 30 composite is, I have not seen that on any other trials ever. It does seem like all the components are important. So, I mean, creatinine rise less so than RRT or death, clearly. And none of the individual components means between close to significance. But then when you combine them, I guess the question is how much importance do we
It's a good point. The editorial that came along with this was pointing out that this is not a clinically significant patient-centered outcome. That the nature is not something you bring up around. They're going to give you crystalloid because the pounds crystalloid because
Yeah.
your chances of make 30 event will be 1% less. But the components of them are really things that if I was a patient, I would care deeply about.
I think I did it. Let me see if I put the number needed to. The number needed to treat was 111.
Okay, it's
Yeah.
pretty high.
It might be a little bit off, but I have one incidence this week that the patient is hypoglycemic and the patient is on lactating triggers. So I asked really the pharmacist, I said, is there some dextrose in it? And he said, none, not at all. So I have to change it to D5 lactating triggers because the patient had been hypoglycemic.
So you could put D5 LR?
Yeah, D5 LR.
No, I didn't know that.
I've never done that.
Yeah, I've never
That's a
known.
thing.
That's a good point. I didn't know that we could do
It makes it
that.
Question, is there a difference in cost?
We're gonna go through that. Shall we? I don't know.
Yeah, I mean, the short story is plasmaloid is quite
Should we
expensive.
go
but
through it now?
and SNLR are equivalent. And quite cheap.
So here's the cost data.
Why is plasmaloid so hard?
The BAL is essentially plasmolite, but you can see actually saline and LR are pretty equivalent. I thought that it would be a much bigger difference, but it's not.
$3.
Yeah, and actually, so this is quoted in a lot of studies. Came out of a cost effectiveness article, and they actually concluded that the use of the BAL fluid or the plasma light was cost effective when you compare like the difference in outcomes with sepsis. But I didn't dive too deep into the article, but they determined it was cost effective, and this is what a lot of the articles are actually citing now.
Why is half normal saline more expensive than normal saline? They're giving you even less saline.
I don't know.
That's the hard question.
Yeah.
One question that I had was like, I think if something started on a patient, the next provider is like more likely to use that based on how you order it, if it's easier to click reorder or continue. So were those patients that had a difference, were they actually the ones that they needed more fluids on the floor, they got more balanced crystalloid on the floor? Like,
Yeah, we don't know.
is it a difference that we don't even know what it is? Like, if they actually looked, it was really the ones who needed 5 liters, and the ones who got all 5 liters of LR were the ones who did better.
No, I think it would be helpful to know that. Yeah.
How much food actually secure the whole.
Right. I didn't see any. There might be in like the supplemental data, but I didn't see anything. But like.
During a 6 there was a critical care topic. They were put fluids essentially 80% of it. She mentioned that like these composite outcomes, there seems to be more of a difference as they get more fluids. So like do some analyses or whatever, one of the critical care things are like what you're saying, they got more of the LR with balanced fluids. They seem to have a better effect.
Yeah, I think that's a good transition into text.
Yeah, that's mentioned in the second article a little bit. So the second article has a much smarter acronym, which is the Isotonic Solution in Major Adverse Renal Events Trial. How they exactly get these things, I'm never quite sure, because I can't really pick out I guess the T is the trial, the R is the renal, but it seems like a real stretch to me, so.
Well, it could be iSmart.
Yeah, iSmart would be better. Actually, that's great. I'm going to write a letter. So they get like 80% points, I think, for coming up with a creative trial name. And the methodology and structure of the trial is quite similar to the non-ICU trial, but we'll discuss some of the key differences. So like the trial that Mona presented, this is unblinded, it's cluster randomized, multiple crossover trial, all at Vanderbilt University. And they looked at some of the similar primary outcomes. The composite outcome was the MAKE 30, and they had a long list of secondary outcomes, which we'll get into a little bit later. The methodology was structured similarly, but there's some key differences. So the way they randomized patients, so it is cluster randomized. So they had 5 different ICUs at the hospital. It was like a medical, cardiology, surgical, neuro, and a blank ICU that I can't remember. So they randomized patients each month within each unit to get either randomized to balanced or non-balanced crystalloids. And then every month they would switch. So like the 2 ICUs that were normal saline 1 month would switch to LR the next month. And the way it actually worked is, so when the patients on that unit, it's kind of a crazy actually trial. I'm surprised, I don't know how they got approval for this, but everyone was automatically enrolled into the trial who came to that unit. And then all the fluids in that unit would be, a BPA for all of those patients within the EMR would guide patients towards the randomized fluid. And the BPA, if there were relative contraindications, would point that out to the provider, and that would be, so if you didn't have relative contraindications, it would push you to that fluid. If you did, it would kind of make you stop and think about what fluid you want. And the relative contraindications were hyperkalemia and traumatic brain injury. So the thinking is that, balanced crystalloid is a little bit more hypotonic, and you may not want to use it in patients with TBI. And like in the SALT-ED trial, providers were able to use the unassigned crystalloid if they thought it was medically helpful or indicated. They analyzed the data on intention to treat analysis. And then this is the baseline demographics of the population of the 15,000 patients that they looked at. Take maybe 20 seconds to just peruse that, and there are a couple of things that are, I think, mildly interesting to point out.
Was this done at the same time as the non-ICU patients?
Very similar times, yeah.
I just wonder how they if they have data from one of them before the other one, how you just roll everybody seeing that the other one showed.
They didn't. They had like a needs assessment or like pilot trial to kind of to figure out how to power their stats. But these trials were going along concomitantly. So if you look at the demographics, they're pretty similar in the two groups in terms of demographics, age, sex, race. Notably, it's 80% Caucasian white population, which is a little bit different than our demographic if you think of the external validity to our group, and probably not unexpected for their location. There was a similar amount of coexisting conditions and renal conditions. And then things that I think are important, so there were similar components of patients who were presenting with sepsis, about 15% in each group. And there was a pretty sick group. So about a third of each group was mechanically ventilated, and a quarter of them were on vasopressors. So sometimes I think that our like floor patients here in the teaching service are like most ICUs in the world. But these are probably a little bit sicker even than the patients that we deal with on a daily basis. Anything else? Yeah.
15% sepsis is, I think that's kind of low. What do you guys think?
Oh, but then these sepsis are from probably mostly from the emergency department.
You said they're different ICUs.
So the different ICUs. So there's medical, surgical, cardiac.
Predominantly because they're septic, so they come to our service. But
Yeah.
But in terms of like relating it to our people that we're using fluids for.
yeah, because we don't have traumatic brain injury, traumatic brain injury.
Right. There are some subgroup analysis that actually looks at some of these different groups. In traumatic brain injury, we're less likely to get the isotonic balanced crystalloid in the first place, so the data might be difficult to apply in those patients anyway. So these are some of the results. So they recruited 15,000 patients in all the ICUs. Similar to the SALT-ED group, there was a median 1 liter administered to each group. And then because of the way the cluster randomization worked and crossover, so every month there was a switchover between in the ICU. If the patient stayed from over that crossover time from 1 month to the next, they would be switched to the other crystalloid. That happened in a surprisingly small amount of patients. So 5% of patients got the unassigned fluid due to just being in the ICU during the crossover time. Does it make sense?
What period are they measuring for these? It seems really shocking that anyone is getting 1 year.
So I think this is like initial fluid resuscitation.
It's like first 24 hours.
Well, so there's more data on that here. This is the cumulative fluid administration in the patients in their ICU, and so cumulatively they got up to 2 liters, but within the first 24 hours it was less than that. Sorry.
Yeah, but even like if these people aren't receiving like the initial, like what we would do for sepsis.
Yeah. What do you resuscitate with 1?
That's a good question.
Is it
Yeah.
keeping you running and building it up?
I mean, we would just think like
Anyone
easy
who's
stuff.
got a patient, anybody who's, I don't know, just like.
Well,
I mean,
most
but
of
only 15% are sepsis, but that raises the question, are we more liberal with fluid here than they're
The
down
patient,
there?
that was it. The patients in our ICU are very likely way sicker than they are in the Bandy ICU.
Yeah.
Why though? It's a tertiary care center. It's like
Yeah,
No, but
in the big city.
like, because I did residency at UVA, which we got, there was actually some crossover with the patients from Bandy, and like our ICUs, because they had more beds, you get like less sick patients there. Like if someone had like a really bad nosebleed, it might be in the ICU, for example.
What quarter of them are on compressors and like getting
And
that
it's
amount of fluid?
Well, it's probably phenylephrine for the nosebleed, but
That makes no sense to me. Like, if they're requiring compressors.
It does seem
and
low.
Not even getting, like, do they even need, maybe if they'd gotten properly fluid resuscitated, they wouldn't have even needed the compressor.
And also, this is like the first week. Like, that's 7 days.
Yeah, they go out to 7 days. Yeah.
So this
It's
is
odd.
median, so maybe.
Yeah,
Median,
maybe.
or the 15% of sepsis probably got more, and then those patients came in with respiratory failure probably got less.
Yeah. The other thing to remember is it includes also the cardiac ICU, so that could be a confounder, right? Because those patients are probably not getting a lot of fluid. Was there anything else here? So, and then the other thing you can see from this this table is that there was relatively little crossover between unassigned fluids in each group. So patients who were assigned to get balanced crystalloid, for the most part, got balanced, and vice versa. So similar to the SALT ED trial, they did show a significant difference in in some of the physiologic parameters. So in patients getting saline, they had higher chloride levels. In patients getting lactated ringers, they had higher bicarbonate levels. And one thing to note is so that on day 0, the chloride is higher in the saline group. That's because the clusterization was matched with the patients coming from the ED. So they were getting the same fluid in the ED that they would get on arrival to the ICU. So they'd already gotten a decent amount of fluid before they got to the ICU. Does that make sense?
They already got the 1 liter in the ECU.
Oh, they really got 3 liters.
We don't know what they got in the ED from the data they report. Presumably they got additional fluid, but it was the same type of fluid that they would have gotten in the unit. Does that make sense? Okay. So these are the major. So this is the primary outcome, which was a significant difference in the MAKE-30 between the balanced crystalloid and saline group. So about 1% reduction in incidence of the MAKE-30 with an NNT of about 94. They did also break it down into the components of the MAKE-30. And while none of them reached statistical significance, they were close to a trend towards significance for in-hospital death and new dialysis among these patients. What do you guys make? Do you feel those are kind of clinically relevant? Are those different than the SALT ED results of non-critically ill? Are they more impressive, less impressive, different?
Closer. So it was like 0.5. For the parts.
You mean for death?
Components of the parts.
Yeah.
Very similar factors, though.
Yeah.
Still looking at that, still looking at.
Did they look at that at all? Like, did they look at what the additives were to various medications? Because in theory, even if people randomized to get balanced crystalloids, like a lot of meds are mixed in NS.
They have to do saline.
Right. Just to say that like those people probably like if they got thing, if they got it.
Yeah, those have to be.
So they probably also got it.
Yeah, they didn't. Too much. I don't think they changed the diluents for drugs. Yeah. Yeah. So ones that were NS would stay NS, and ones that were D5 would stay D5. Yeah.
That's true. We never really factor in like the fluid volumes that are given with the antibiotics you get, and sometimes we're giving patients like if you give them IV antibiotics, you're giving at least fluids that way.
But to me, this is pretty impressive. I mean, there's like a near statistically significant 1% reduction in death from patients who got balanced crystalloid versus NS, which is obviously a clinically significant outcome. And you wonder if they had been slightly more powered, would they have found a statistically significant difference. They looked at a lot of secondary outcomes, which I didn't put up here. They looked at markers of clinical stability in the ICU, whether they're on vasopressor-free days, ICU-free days. There were no differences in any of those, and no differences in other renal-specific markers.
And you say they didn't look at correlation between the amount of fluid received and outcomes?
Fantastic question. So they did a large subgroup analysis, and they did look at quite a few things, including that. So that piece of data is actually not pictured here. It's in one of the supplements. But they looked at amount of fluid received, and the difference was more pronounced the more fluid they had received. So in patients who got 3 liters of NS or 3 liters of LR, the difference was bigger. They were more likely to benefit by getting balanced crystalloid. Does that make sense? So if it was on this graph, it would be towards the left and significantly towards the left. Other things that were associated with an improved response to balanced crystalloids were sepsis. So patients with sepsis were particularly likely to benefit from balanced over NS, and patients in the medical ICU were more likely to benefit. Anything else in there that looks striking to you?
So did they look at lactates when they looked at the balanced crystalloids?
Did they measure lactate?
Yeah, did they look at that?
So
As in like a marker of improving your sepsis?
Yeah.
I'm not sure. I don't think so.
were you asking about lactate contribution from the water?
Yeah.
Oh, okay.
Like, do they even look at, because if you're resuscitating to the lactate, which is what we do, but there's no evidence to do that either, right?
So I actually tried to look into that,
Yeah.
and there's really not that much out there. the things that say like there's a theoretical increase in the lactate, but I don't think it's not.
You have to give a ton of lactate, and so it's not lactic acid in the bag, right? It's sodium lactate. So you have to give enough sodium lactate.
Thought like theoretically that it contributes, right?
But I don't think to a significant degree. But
Yeah, discuss it with a nephrologist, and you have to give enough lactate to really shift the curve between like lactate and lactic acid to actually make it measurable. And on that, you don't know exactly what that is. It was probably many bags of lactate.
It's not actually lactate, but lactate.
Right. It's
not stable in solution.
yeah. So it's sodium. Yeah, it's like sodium. Yeah, exactly.
Yes, my question would be, why wouldn't you use LR?
Yeah.
If it doesn't cost more, and there might be a theoretical benefit, why wouldn't you? Why wouldn't any of you not use it?
Historical bias of being trained to use internal sand.
Actually, it depends if you're a medicine or surgeon. So,
Right. Well, I mean, for
so
sure.
it's like, yeah,
I wonder why the surgeons always use LR.
it's been there forever.
Yeah.
It's like, yeah.
I think in the past LR was more expensive, but clearly it's not.
I was shocked by the cost.
Yeah.
Because that would be my reason not to use it, but if it's not, then like we might as well just be using it.
I would argue that this is not practice changing. I think this builds on some articles that were already out there. We already had some conflicting articles showing there was less AKI. There's one JAMA in 2012
Yeah, I went over that in the
So,
beginning.
like, yes, this is more evidence that we probably should be using BOF solutions, but I don't think it's, to me, this is too much.
I think Mona's first slide showing the difference between the fluids was more effective than most studies.
Oh, you mean the
Like, just
composition
to kind
of
of
the fluids?
to convince you that why you should use one over the other. Like
Well,
the
but just because they're like
composition of the fluids.
physiologic doesn't mean that one is better than the other. And just because it looks more like your blood.
That's true, but I didn't feel that the results were that impressive. Surely, Mike was saying, I guess we had evidence which kind of shows, but it's still not practice changing based on just that.
Well, I think like the evidence that I showed before, the background data, like they weren't randomized studies. They weren't like
They were
well done. So I think like this is practice changing because these are randomized controlled studies and they're showing like true benefits.
Yeah, the preponderance.
They confirm what the other ones showed, but
And also, I mean, we kind of said that the change wasn't that big, but 1%, because we give fluids to almost every patient that comes here, right? 1% of 1,000 patients is still 10%. 10 patients that you're saving from a major, death or major renal complication. Like that's a lot.
especially like if it's more effective in like sepsis in the medical ICU, and you pretty much give everyone
They don't want any like blood transfusions in relation to the.
I didn't see any data on other like non-crystalloid administration.
Yeah, data in the ICU getting.
Yeah.
It's not very clear what exactly they're treating, right? Like I mean, some of them are intubated, some of them are processed, some of them have sepsis.
Yeah, it's not. I mean, if they'd had enough data, like power, it would have been nice to break it down by all those subgroups.
I guess we can go back to the original